My relevant disclosures are related to my work with Don Joy Orthopedics, and a lot of the work that I do shows DJO implants. So some of this, it was just reviewed by Frank. Incidence of periprosthetic fractures, 1 to 2% of all shoulder arthroplasties, up to 11% of total shoulder complications. I'd say I don't necessarily agree with that literature, but that's what's out there. Risk factors being age, female sex, osteopenia, and rheumatoid arthritis. But I'll tell you, in my opinion, most periprosthetic fractures are associated with arthroplasty done for fracture. And so based on that, periprosthetic fractures in my practice for total shoulder arthroplasty, they're just pretty rare. Wright and Crowfield classification was just reviewed, and it's probably the one that's used the most. A, B, and C. A starts at the tip and goes up. B is at the level of the distal stem, and then C goes below. And C's you often just treat just like regular fractures. So from a treatment, I think the best treatment guides actually, it comes from the article out of Mark Frankel's group, where they basically realize that, you know, the decision of what to do to the stem is really dictated by whether it's loose or not. And so as you're managing these periprosthetic fractures, you got to figure out first and foremost, is that stem loose or is it stable? And that changes what you do. In a well-fixed stem, you can get away with fixing it, and a variety of different techniques for that. But if the only other reason that you would revise a well-fixed stem in the setting of fracture is if there's other pathology and you're just trying to hit a grand slam, treating the underlying failed arthroplasty and then removing the well-fixed implant and fixing the fracture at the same time. So, you know, a loose stem like this, it gets revised with a long stem in this case and cables, and it requires a complete revision because the stem is loose. So why would you do a reverse? Well, gosh, the main reason we do a reverse is because, like every other revision of a total shoulder arthroplasty, reverse is such a crazy, amazing workhorse in the ability to manage a variety of pathology that are often presented with a total shoulder, like cuff disease and instability and all of these things that can't be managed by just fixing the fracture. And so here's a case of, you know, like I said, it's pretty rare for me to find total shoulders that get fractures. But here's a 56-year-old male. I treated him for osteoarthritis, pretty straightforward anatomic shoulder replacement. 4 years later, he was lost to follow-up, but he comes in complaining of pain and instability. And so he had this sort of rare graded tuberosity avulsion fracture with instability. So we tried to treat him non-operatively, but he's a really big guy, and it didn't work out so well because at 6 weeks, he comes in and he's completely dislocated. He's actually locked in this dislocated position. And so trying to manage this with anything other than reverse this won't work, because you're dealing with a massive rotator cuff avulsion, actually glenoid bone loss that occurred on the other side of the well-fixed glenoid. And so these problems have to be treated with something a little bit more sophisticated, and a reverse shoulder replacement can just manage it very, very well. And so I did that case recently. Here's another case, a 67-year-old female, rheumatoid arthritis. So she does have a risk for periprosthetic fracture. She's female and rheumatoid. I did an anatomic shoulder. She needed a bigger head because she had a balancing issue. Her glenoid came loose years ago, and she was stable with it until she fell. And actually, this stem was actually well fixed, but the glenoid wasn't. And so here's an opportunity where you're doing a revision and managing the periprosthetic fracture. Yes, I could get away with by just fixing the fracture, but really she had poor function and very, very unhappy total shoulder before she fell. So she gets revised to a long stem. And this actual case highlights a variety of different techniques that can be done in managing these fractures. So the glenoid aside, because it had its own unique challenges, but on the humerus, it was a very, very small humerus, and in trying to place the humeral component where you want it, in this case, I did what would be considered unconventional, which is putting in a shorter stem, fixing the fracture below it, and just using cement up top. I'd say traditional thinking would be to put a long stem, but it becomes very difficult in managing that fracture. And utilizing some of the newer technologies allows you to actually accomplish all the goals by fixing the fracture and still doing the revision. And because the reverse is such a great workhorse in managing all of the pathology here, it can do well. And for the first time in 5 years, she's lifting her arm above her head. And here you can see some of the techniques that I'll highlight in a second, but a Skive screw technique utilizing a plate that allows you to dodge the implant is very effective at putting bicortical screw fixation if you're choosing to use fracture fixation for this. So here you see that screw technique. We published this years ago in the JOT, Journal of Orthopedic Trauma, 2016, utilizing this particular plate that you see on the right. I've got no disclosures related to that. It's a Synthes 3545 metaphyseal plate, but the oblong holes that you see at the top really give you an opportunity to shoot screws around the stem. And certainly if the original arthroplasty surgeon was kind enough not to fit and fill the entire humerus with metal, it gives you opportunity to actually throw Skive screws, and you can even add cerclage wires to enhance the fixation. So yeah, this was another Skive screw technique in just an 86-year-old patient who had a total shoulder arthroplasty, and he did well until he fell, periprosthetic fracture. And this was a case where the bone quality was okay, but the stem was not loose. And so without a loose stem, I'm putting in a fixation technique.
Oh, set.
So that's all I have to say about periprosthetic fractures. I do think that in the setting of total shoulder, you just don't see it that often. But if the stem's loose, revise it. If you need to do more, go for the home run and do a reverse, because it can do pretty much everything you need to manage all the pathology. Thank you.